can everybody hear me okay without it?
No.
No? Okay. All right. I didn't want to use it, but...
You got to be close to your mouth. We got an old system here.
So I'll be quick because I think this will generate a lot more questions than answers. So I'll probably give like a 5-minute overview. Quickly, I work for the Innovations Division of Johns Hopkins up in Baltimore. I work remotely. I was with Vacca Health System, then Florida Blue for 5 years. And then with Hopkins, our role is to be glued to the School of Public Health's hip with their scientific research and latest cutting edge innovation. And then what we do with our team of statisticians and scientists is bring that to the commercial marketplace to help physicians, health systems around the globe manage their populations and increase the quality of their health outcomes and costs. So I lead a team of statisticians under me. I'm trained in biostatistics myself and have been with Hopkins now a little over a year. So today, Bill and I were having coffee. Unfortunately, he couldn't be here. And we were talking about social determinants of health, economic development, and how the clinical outcomes are being tied to that now in the new modern healthcare space, and how providers are going to start to be reimbursed for that, for keeping their patients healthy, for solving some of these issues. So I'll kind of give a 5-minute overview. I'll try to keep it as local as possible and not go too far out into the United States or the world. So I'll kind of start with that, tie it all together, and kind of give the missing pieces and give a lot of room for questions. So if you think about East Tampa, just quadrants, north, south, and west, all will have different health outcomes. All will have different life expectancies. All will have different costs. All will have increases, a certain amount of chronic conditions associated with them, all based on their zip code, their census tract, their race and ethnicity. And to date, up until about 10 years ago, nobody had really ever tied the clinical data and the predictive modeling that we do on cost and utilization to social and environmental influences. So that's what we started to do at Hopkins a long time ago, and now our team kind of does now in our population health team. And we work with local health systems like Tampa General. I don't think we work with Baycare, Advent, other physician groups who come to us and say, you know, can you look at our populations for us? Can you identify what's going on in our populations, and can you help us create health equity plans in order to close some of these gaps and help with achieving some of these outcomes? And there's a few missing pieces in there that I'll get to in a minute. So whenever we start, we'll go into and say, oh, you know, we've looked at East Tampa down to the census tract level, and we can identify that these subpopulations have food insecurity issues or transportation issues. And for those reasons, when you correlate that data to their clinical outcomes or their cost outcomes, you notice that they can't get to their doctor's appointment. So they use the ER, which becomes a cost and a burden on the healthcare system and a burden on that ER physician who's working at 2 a.m. in the morning. It's also a burden on their families and the whole economic system as a whole, because they can't go to work the next day, they lose time, the employer loses their employee for a day. So these have broader implications. And then from that place, we start at the population level and say, now what we're trying to do and work with physicians and community leaders to do is say, okay, now you need to capture the diagnosis. And there's a whole new set of diagnosis codes I won't bore you with, Z codes that capture those individual level markers of this person has a food insecurity issue. They have an immediate need, because not everybody in a census tract or a zip code may have an educational issue. Some people in 33606 might not have a degree, some do. You don't know until you capture that data properly. Once you start to capture it, now you can start to identify, oh, this person has an immediate healthcare need I need to address that is of social nature. And from there, it's either the health system's job, the care manager's job, or a community, a partnership that needs to be formed to close those gaps. I remember Baycare Health System did a little deal with Uber a while back to get seniors to their appointments. And it can be any influence. It's not always economic. It can be somebody in, I'll never forget, there was a Medicare Advantage patient in South Florida, had a ton of money, up in a condo, living alone, had dementia. Care manager goes up there one day, house is a mess, she's on the floor, never had any access to care. So it's not always an economic factor that drives some of these things. The other things that drive some of these influences outside of transportation are things like walkability. Like go look at Bayshore and then go look at another part of Tampa and you can tell the difference. So those are the things that we kind of look at on a daily basis. I won't bore you with the math that we get to do on a day. I think it's fun. The math and the science and the modeling that we try to take in all these large sets of clinical data that are de-identified and combine that with social determinants of health to find these correlations at population levels, and then go to these physician systems to say, hey, you know, you have an issue in this population, you need to start paying attention to this in a serious manner, because this has, I think, what people miss. One, there's a lack of partnership between the community leaders and the health systems. Not all physicians can get a healthy meal to their patient, right? That's not always on the physician per se. There's the missing piece of lack of collaboration, and then there's the missing piece of the broader implications on the economy, on local workforces. If you're not showing up to work in a healthy manner, if governments don't make policies with healthcare in mind and health outcomes in mind, we're going to continue on the unsustainable path that we are in the American healthcare economy, which is continuing to spend more and continuing to kind of get average outcomes. That's not in every sector of the healthcare industry. Our R&D, I think, is still some of the best in the United States. I still think we have some of the best surgeons in health systems, but overall we're on this unsustainable path, and we use this data every day, try to tie it together, try to use that clinical and social data to get in and write these plans for these physician groups or community leaders to say, you need to create a better path to these outcomes. It's not only good on the incentive side for paying people for value instead of just charging them for their healthcare service, but it's also good in the broader economic activity of a region and the health of a whole population of a city. You know, like a growing city like Tampa Bay, for example. So that's my 5-minute overview of a very complex subject. I avoided all the mathematical modeling. And from that, I kind of think my hypothesis is there's going to be a bunch of questions. So please, I'm happy to answer the broad or specific as possible.
You keep that.
Okay.
I'll use this one over.